Okay, I think we can start. I just received a text from our Airlib Hospital Grand Round team. They are all set. We have a lot of the viewers online. So thank you so much, friends, for spending your lunchtime today on the 10th with us. Happy New Year to all of you. We would like to welcome the four hospitals on the Hospital Grand Round team. This is the first time we are doing this, where this presentation is being live webcast for four hospital campuses through their Grand Round program in the auditorium. And I just got a green light from them. They can hear us well, they can see the screen. Welcome everyone on for today's call. And topic for today is clinical and regulatory review for the topic is cellulitis. And we'll go through some slides, and a lot of you who are on the system, or a lot of the hospitals that are on the system already have access to the Aerolib learning management system. I'll spend a few slides telling how to get access to them. If there's any questions that you have, feel free to put that in the chat box or text me, and then we can answer those. So the learning management system is our e-learning platform for clinical and regulatory education. When you go on to aerolib.com and scroll down, there's a tab called the Aerolib LMS. Clicking on it will bring you to the Adobe Captivate Prime login page that a lot of the users already have usernames and logins for these. The ones that are on the webinar today for a live recording may not have it, but if you do need it, feel free to get in touch with me and we can arrange that. So the clicking on or logging in will bring you to the learners page, where you can see a lot of the presentation topics. Choosing any, for example, acute kidney injury, will open up another page where you'll have access to the video, the references, the PowerPoint slides. You can see what sort of courses you've completed, how many minutes you've spent on them. You can compare yourself with your colleagues. What we have as a free resource for a lot of the users is the Aorta app, which is available on the iOS platform or the Android platform, and we've had more than 100,000 views with more than 170 members. This is a free app you can use, and it's mainly used for discussions of common issues. So on the right hand screen, I've put in, there's a lot of discussions about condition code 44. There's some flow sheets that you have, and this is pretty much regulations in the palm of your hand. Now, the topics that we have already done since we started early last year, in terms of clinical and regulatory topics, we've done COPD, sepsis, acute kidney injury, pneumonia, CHF, seizures, abdominal pain, TIA, syncope, atrial arrhythmias. So pretty much the bread and butter of what hospitals do for medical admissions. And in each of these presentations, like you'll see in our cellulitis topics, we cover the 2 midnight rule, the spectrum of regulators, what's important in documentation, what are the red flags, what are the MCCs, CCs, secondary diagnosis. We touch about ICD-10, and then basically give you tips on how to document medical necessity. Now, in addition to these topics, we've also put in acute respiratory failure, topics like case analysis for audits, 3D mapping of clinical data, physician advisor basics, anatomy of a record, the Moon notice, condition code 44, value proposition of a physician advisor program. Ones that have been added in the last 3 months are chest pain, acute MI, UTI. Ones that are going to be coming up are blood transfusions, macra MIPS, HCCs is already on. The perfect appeal letter is being made right now. What we have done beginning of this year is new video presentations. So thank you to the healthcare conference administrators. They have allowed us to use 3 video presentations with Judge Bob Soltis from the 4th National Physician Advisor Conference. In addition, Aerolib and Appeal Academy have tied up, and we have produced 2 really good webinars with former ALJ Bob Soltis on about proposed decisions, what happens during an appeals process. And so this is going to be very interesting for not only the case managers of the appeals and audits staff, but physicians to know on what actually happens 2-3 years down the line when their cases are audited. Now, a little disclaimer that, when we refer to CPT, it is a trademark of American Medical Association. When we refer to screening criteria, we may be referring to Interqual, which is a product of McKesson. Um, so let's start with the basic slide on who are the spectrum of auditors. And a lot of you in the hospitals that have been listening to us know that we always start with this, trying to give an overview of who is auditing the hospitals, who is auditing the healthcare providers. And this is a traffic light pattern. So the green is the good, or which means which is on our side, which helps us. And so this is for routine compliance, the QIOs and the certs. When we go on to the yellow band, these are the max, mix, and racks, and these are compliance oversight. Now, what we have to be careful is the legal oversight organizations like DOJ, the Department of Justice, Office of Inspector General, and then the ZPICs. Now, in addition, when we talk about spectrum of auditors, you need to know your payers are also auditing you. So insurance companies, they're sending notice of improper payments and recoupment if they feel that the care was not provided adequately. Now, when Medicare released the MACRA reform, they introduced the MIPS, or the merit-based incentive payment system, and the alternative payment models. And we'll talk about how this fits in terms of payments and in terms of what we're going to talk about today. So in short, when you just see this slide summary from CMS, it talks about payment reform. And what they want is, documentation of quality, resource use, clinical practice improvement activities, meaningful use of EHR technology, or through the APM. What it would mean is 2017 is the base collection year for data, and then payments start changing, which means you could either get 4% more or 4% less every year from 2019 onwards. And you can see it's 4, 5, 7, up to 9% up to 2026. And we're going to tie this up on why this is important for what we're doing today. Now, in addition to the MACRA, MIPS, APM, there's these next generation ACOs, comprehensive primary care plus programs, chronic care management programs. And in short, it is payment reform. What it doesn't change is documentation requirements that we as providers need to put in. So what do these auditors look for? And technically they're looking for documentation that the service that you provided, whether you as a provider or you as the hospital, whether you provided that in the hospital setting, are these reasonable and are these medically necessary? And they need to meet professionally recognized standards of care. And these services, could they be provided in another setting? So these are some of the litmus tests, questions that we need to answer when we're doing our documentation. Now, a lot of times they're not only looking for documentation, and I'm not going to read these next two slides. These are busy slides. People who have access to the LMS can pause at this time and read the spectrum of auditing. So there is kickbacks, inducements, false claims. I think where we focus on is documentation, false coding services, unnecessary care. We talk about altering medical records, delay in care, and then they're also looking at physician office errors. So why is cellulitis important? Well, one, it's an expensive disease, and we'll talk about some numbers, but in terms of measures for 2019 reporting, cellulitis payment is an episode-based payment measure that CMS has put in. And this is a slide from Medicare Learning Network Connects. We have links to these if you need to look at the entire presentation. So let's start with our topic of cellulitis. People familiar with the call know that, we talk about some definitions, some pathophysiology. We look at signs and symptoms, secondary diagnosis, and pretty much talk about the spectrum of disease, not only from a physician standpoint, but from a hospital standpoint, from a payer standpoint, on what needs to be added on this. So we'll start off with a case first. And the idea of this case is to just stimulate your thought, and we'll answer this towards the end. So a 73-year-old female presenting with the 4-day history of worsening left foot swelling, warmth, tenderness. There's red streaking lymphangitis up to the thigh, with difficulty walking and weight bearing. So the treatment provided is, IV fluids, blood cultures, IV Teflaro, imaging showing possible osteomyelitis. Diagnosis is left foot cellulitis and osteomyelitis, and patient is discharged with a PICC line, long-term antibiotics, ortho and ID follow-up, and they submit a bill for $10,500 for this 3-day stay. And our question is, should the hospital get paid? And as we go through, you'll notice, you'll find the answer to this question. So why we are concerned about cellulitis is that cellulitis is an expensive disease. This is the average amount that hospitals in New Jersey charge for the diagnosis of cellulitis with MCCs. And this is public data. It's from a CMS website. They have listed the name of the hospital, the city, the number of discharges, what they charge, and what was paid. And this is Medicare only. You can see the variation of what hospitals charge for cellulitis with MCCs, way up to 118,000, and we've only chosen the top few hospitals, but this goes down to 30,000. So there's a huge variation in what they charge. But look at what they get paid, and there's not much variation. It ranges from 12 to 13.5 to 14,000, highest being about 15, lowest being 9, so not much variation. So what it means to say is episode-based care for cellulitis, there is standardized data on what the government pays, and this is what is being followed by other payers. So let's talk about a definition of cellulitis, and we know it's a bacterial infection that affects and spreads in the skin and soft tissues. The signs and symptoms are pain, tenderness, reddening in the affected area, fever, chills, and lymphadenopathy. Now, why this is important, and you'll see the next few slides just focus on a bunch of definitions, but towards when we start discussing payment criteria and the use of screening criteria, this will all be replicated. And the idea is payment and screening criteria do not develop their own medicine. They actually pull it out from what we have learned in med school. So the Harrisons, the Davidsons, these are the standard textbooks that talk about the definition of cellulitis, and this is what forms the basis for payment reforms for cellulitis. Now, other definitions are an acute, diffuse, suppurative, inflammatory changes of loose connective tissue, acute spreading infection of the deep tissues of the skin and muscle. And again, words that you will see that are repeated are fever, chills, swollen lymph nodes, blisters. From a pathophysiology, legs and face are the most common site involved. And again, this is data from hospital patients with cellulitis as the DRG. Risk factors include obesity, leg swelling, and old age. And why this will turn out to be important is all this will be used, this semantics, wordings will be used to develop our history and physical, to develop our progress note, to develop the medical probability of adverse events happening. And that's where risk factors come in. So most common bacteria, Staphylococcus aureus. In contrast to cellulitis, erysipelas is a bacterial infection involving the more superficial layers of the skin. Bacterial infections, they affect about 155 million people. Cellulitis itself was billed in 37 million people, and it is a dangerous disease. It causes about 30,000 deaths worldwide. So there was a big topic from one of the Pennsylvania auditors on skin and soft tissue infections or cellulitis among long-term care facility residents. And these are our nursing home patients who will present to our hospital as direct admits or through the ER. There's a prevalence of 1 to 9%, and cellulitis along with infected pressure or decubitus ulcers are two of the most common types of skin and soft tissue infections in nursing home population. Now, there's a very nice article about the practice guidelines for diagnosis management of skin and soft tissue infections by the IDSA. And when you have access to the LMS, all you need to do is click on this link. It will take you directly to the article and you can see it. We are not going to discuss this algorithm. The purpose of today's talk is to give an overview picture of cellulitis from clinical and regulatory standpoint. But take some time, look at this wound care cellulitis algorithm at your leisure. Now, untreated cellulitis, can cause septicemia, osteomyelitis, lymphangitis, endocarditis, meningitis shock, and gangrene and tissue death. And why this is important is many a times the reason for hospitalization falls into the spectrum of the complications that are being caused by cellulitis, or the concern that this may happen, and that's why this patient needs an extra day of stay or extra 2 days of stay, including this sort of imaging that can only happen in the hospital setting. So, cellulitis is not just an inpatient or an observation or a hospitalization diagnosis. Majority of the cellulitis can be treated as an outpatient. Now, again, risk factors are impaired immune system. So someone on chronic prednisone, on neoplastic agents, chronic illnesses, skin conditions. So if there is severe eczema, new worsening shingles, there's lymphedema, obesity, and there's a history of cellulitis. So in case of hidradenitis suppurativa, which is disabling, that may require hospitalization. And again, why this is all important is these are the same semantic keywords that auditors look for in order to approve your payment for the case of cellulitis. So simply put, documentation needs to have wordings of erythema, pain, swelling, warmth, lymphangitic spread, systemic signs of illness. So is there fever? Is there altered mental status? Is there tachypnea, tachycardia, hypotension? Is there abscess formation, whether it's purulent or non-purulent, or is there ulceration? And again, this has been documented many a times, right from medical school literature to some new guidelines for practice guidelines for management of skin and soft tissue infections. So what we need to do is specify site. We need to specify whether there is lymphangitis or not, specify laterality, and that was the basis where ICD-10 came in. A lot of their codes were laterality for orthopedic procedures. But many a times we have seen during our process with a number of cases that we look, physicians and providers just fail to put in if this is a right foot cellulitis or a left foot cellulitis. Now, underlying conditions, is there foreign body, Crohn's disease, trauma, indicate organisms or infectious agents if they're known or if they're suspected. So if a patient has a history of MRSA cellulitis and now presents with same site, same segment cellulitis, you will not be penalized or wrong in assuming that this may be a reoccurrence of MRSA cellulitis with possible MRSA osteomyelitis. So that's where the thought process needs to come in when you're making your progress notes. So specify site, and this is a simple thing to say, but it is missed more number of times than any portion of cellulitis documentation. So if it's the face, if it's the head, upper limb, lower limbs, trunk, be as specific as possible. If there is associated fever, make sure you document what you think the fever is from. Is this from the cellulitic or the surge process? Is this a post-procedural fever, transfusion reaction, medication related, post-vaccination? This is to determine the severity of illness that a patient presents in the hospital with cellulitis, is what sort of fever it is, how high it is, and if there is any underlying cause of that. Now, if there's infection, you need to document, is this post-operative if you know the organism? Is this the first time you're seeing this infection? Is it a subsequent, or is there recurrence? If it is due to an implanted device or foreign body, make sure that's put in the documentation. So chest wall cellulitis in a patient who recently had a pacemaker insertion and the pacemaker site looks red, erythematous with crusting and pus coming out, that is not a simple cellulitis. That is because this patient had this pacemaker and maybe the procedure was where the organism entered. When you have ulcers, you need to specify their site, laterality, stages, whether these are pressure or non-pressure ulcers, and in case of hospitals, whether they're present on admission or not. I think the next few slides, we will talk about ulcers in terms of stage 1, 2, 3, and 4. I won't be reading everything on the slide, but the pictures will speak for themselves, and if you need more references, pause this on the LMS presentations, take a look at this. But when you look at stage 1 ulcers, you can see some blanching. Move on to stage 2, this is partial thickness. Stage 3 is where you have full thickness, and stage 4 is when you can actually see the bone, tendon, or muscle. And a lot of times, I know in the Aerolab Hospitalist Grand Round, there's a wound care team that's on. They are the ones that do these initial evaluations, and physicians co-sign them as as agreeing with the wound care team, and that's perfectly normal as long as all this is documented. Now, when you have cellulitis with sepsis and shock, this, you need to link the source of the infection. So, are these vascular grafts, devices, implants? What sort of organism do you think? And then what type of shock do you think is happening? Hemorrhagic, septic, cardiogenic? The LMS has a very good presentation on sepsis, the new definitions, the old source criteria. So when you get some time, you can pause this, or once you're done with this presentation, you go on to the sepsis presentation and look at what's needed for full sepsis guideline documentation. HIV status. I know two of our client hospitals are in an underserved area where they have a high proportion of HIV patients. And so to document whether the cellulitis is from the typical HIV bugs or co-infections, are these asymptomatic or whether these are symptomatic. A lot of the patients that we see who are being admitted for cellulitis already have diabetes and their complications. And so, peripheral vascular disease and amputations, and that's what builds up the intensity of the diagnosis. Now, I pause at this slide, and this is the first time we're introducing this. I know a lot of people have asked us in our previous presentations, is ICD-10 really important? And I tell them ICD-10 does have these diagnoses also. If you look at the top one, there's accidental striking against or bumped into by another person, initial encounter. There's problems in relationship with in-laws, sucked into a jet engine, subsequent encounter. And my favorite is R46-1, which is a bizarre personal appearance. So ICD-10 does make things, spreads them out in terms of number of codes. This is some of the the funnier ones. But for cellulitis, they are very logical in what they would want. And so this is the L series, right from 00 to 99. They talk about skin and soft tissues, bullous disorders, dermatitis, eczema, papillosquamous, urticaria, radiation-related disorders of skin appendages, and intraoperative or post-procedural complications. And then the last 20 are the other disorders. So they have categorized them into what seems like a logical classification. And ICD-10 again is specificity. That's they want you to be as specific as possible, right up to the 7th digit, if it's possible. Now, how this affects documentation is there's another set of semantics called comorbid conditions or major complications or major comorbid conditions, or the MCCs. And what these do is these are secondary diagnoses that increase the severity of illness. They give you more information on the morbidity, mortality, and estimated length of stay, and then also guide into utilization of resources. So CCs are comorbid or complicating conditions. MCCs are major CCs, or that contribute substantially greater. A lot of this is semantics. We already know what comprises of these, and I'll read. I won't read the entire next few slides, but this is where you can pause. This is the time when, if you have a real patient with cellulitis, you can look. Is there altered mental status? Is there, if it is it an encephalopathy? Is it metabolic? Is it toxic? Does this patient have end-stage renal disease? So this is where you want to be as specific in your documentation as possible. And when an auditor looks at the case, they know this is not a simple left foot cellulitis, but this patient had other comorbid conditions and listed as MCCs that complicated the care, or that's why it's justified that this patient stayed for X number of days. And this is where we have some other MCCs. This is CMS semantics, terminology. So instead of writing anemia when this patient is bleeding, write acute blood loss anemia, if you know why the reason is. If this is a cardiac arrhythmia, try and be specific. Get an EKG, know if it's an atrial flutter, if it's a VTAC, if it's an SVT, but be as specific as possible on your documentation. So continued stay. Now, a lot of times, the H&Ps are done perfectly. The discharge summaries, they have an 80% compliance rate. It's the progress notes, especially the ones done on a Saturday and Sunday. That's where majority of the issues come up. And those progress notes should answer questions in terms of severity of illness and intensity of service. So what is the condition that can only be treated in your acute care facility or in the hospital? Now, once you've identified that, what treatment are you providing that can only be done in that facility? So for example, if it's a simple cellulitis of the little finger, you've identified this is a finger cellulitis, but you haven't justified why you need this patient to be in the hospital. Versus if this is a new amputation, post-stump, redness, pus, you've identified the condition and there's a risk of stump osteo or worsening cellulitis and sepsis and pressures are low, and that's the treatment, and you're providing fluid support, hemodynamic support, IV antibiotics. So this should be answered in each progress note as an independent standalone note, that if pulled out from a series of a 10-day stay, we can say, yes, we will approve the third day, the fourth day, because this is what the condition was, this is the patient's condition, this is what the hospital was doing. A lot of times, all these conditions are satisfied, but the progress note is a copy-paste saying, continue what we did yesterday. And that doesn't justify on why we need to pay today. Was there an escalation of therapy or de-escalation of therapy? Was there worsening of clinical symptoms? Or is the patient improving and you want to make sure, or there are barriers to discharge where a PICC line can't be obtained, and that's why this patient needs 3 times a day IV antibiotics that can only be done today until a next day PICC line is obtained, so document, make the story that continued stay management is approved. Now in the progress notes for cellulitis, and this is something we talk about every day, we do reviews for cellulitis pretty much every 1 or 2 days, and our discussions with the providers always include, please document size, length, width, depth, color, odor, with and without discharge, improvement or change in wound with every subsequent day. That is the basics of a cellulitis documentation, not only for H&P or discharge, but for progress notes. Now, screening guidelines. Now, Medicare does not endorse any particular screening guideline, but if the ones that are around there, so Interqual or MCG, they talk about cellulitis, and a lot of what they use in terms of their criteria is what we've discussed in our previous slides, and which has been pulled out from Harrison's and Davison's. So most patients with cellulitis should be placed in OBS unless they have a criteria for severity of illness or intensity of service. So let's look at those now. So when they talk about a criteria for severity of illness, they talk about, the presence of cellulitis, but failure of outpatient treatment with more than 5 doses of antibiotics, and this is arbitrary. If you choose an antibiotic that only needs to be given once in a day or once in 2 days, depending if there's renal failure and you're treating on a dialysis center, this is where you need to document. Progression despite 24 hours of outpatient treatment, and that's obvious. This is failure of outpatient treatment. You tried to do it as an outpatient, didn't work, patient came in. If there's purpura or petechiae, so documentation of, if there's a microplatelet process going on, if the patient's on long-term steroids, if ITP is going on, involvement of more than 50% of one limb or 10% of body surface area, ANC levels. Now again, this is from evidence-based guideline to show that if ANC is less than 500, patient has fever, there's a risk of febrile neutropenia and risk of sepsis, and death is higher. So they didn't create this criteria. It's been around. They've just compiled it into what seems like, yes, this would make it to justify a hospital stay. Animal bites, herpes zoster, toxic shock syndrome. Let's look at some of the criteria for intensity of service. So IV antibiotics and ANC less than 500, cultures, continuing fever, IV fluids. And again, this is something that we need to document, putting just a black and white 125 cc's NR or 100 cc NR. That should not be the criteria for inpatient or observation. What you need to say in your documentation is you think this patient is dry, there's the oral mucosa is dry, there's ketones on the urine analysis, she's an 85-year-old, she has a history of CHF, EF is 30%. You will not give her 125 cc's an hour for 4, 6, or 10 hours. she may just require 40 or 50 cc's an hour, but you're monitoring urine output, you're looking at clinicals, you're looking at cap refills, and that's where the documentation is. That's where the auditor will look at and say, yes, even though our screening guidelines have this particular rate of flow of IV fluids, I think this provider, this hospital did the right thing by giving what they gave. Talk about labs, and so BU and creatinine ratios, sodiums, NPO monitor. If this patient is NPO, active vomiting, unresponsive to antiemetics, unable to tolerate oral antibiotics. So this is where you are painting the picture. Now the screening guidelines. These are based out of medical evidence-based criteria. It's for you to now paint the picture that now also encompasses the screening guidelines. Now, some other screening guidelines, and this I've already mentioned in our clinical presentation, is if there's suspicion for necrotizing fasciitis, if there's suspected sepsis, immunocompromised status, body surface area, if there's burns or cellulitis affecting more than 9%, some have a 9%, some have a 10%. If there's an abscess along with that cellulitis, failed outpatient treatments, unstable vital signs. Now, the idea for this sort of guideline is to encourage your providers, your hospitalists, your surgeons, that when they are writing to justify inpatient level of service or to justify hospitalization, these are the semantics that are being looked at, not only by payers but by CMS, and these are technically the right semantics to put in right from a medical school knowledge standpoint also. So what do auditors look for? They're looking for medical necessity, they're looking for documentation, they're looking for coverage, procedures, imaging. If we can do a rock solid documentation, it prevents us from being in this queue of appeals, which at this stage of 2017 January stands at about 800,000, valued at 4.6 billion. So this is the amount of money that hospital reimbursement money that's stuck in the system, and it may take 4 or 5 years for this appeals backlog to go away. So the treatment to treat today, get paid today, and not worry of being in that queue is why the LMS was started for a few of our hospitals early last year. Now, Medicare does release their compliance newsletter guidelines, and this is guidance to address billing errors. This is the one I pulled out from 2011, and again, it's an 11-page report. It's available online. We can get you a link on this. Links at the end of the presentation. People with LMS, just click on it. It will take you to this compliance newsletter. But when we look at one of the pages, page 5, they talk about debridement incorrect coding. And so they are talking pretty much to what we have been discussing is, what was the procedure done? Why was it done? What was the extent of the procedure? And again, specificity in documentation. So let's look at our case back now. Just to recollect, 73-year-old female, 4-day history of worsening left foot swelling, warmth, tenderness, red streaking lymphangitis, difficulty walking, weight-bearing issues. They did, good description, IV fluids, blood cultures, broad spectrum antibiotics, imaging osteo, diagnosis of osteo, PICC line, but they didn't get paid. And the reason is, this is a real case. It was a documentation error. Patient had a left above knee amputation. The cellulitis and the osteomyelitis was on the right side, not the left side. And the letter that the insurance company sent is, they did the scrubbing of the patient chart. They figured that left-sided cellulitis will not be a payable or a reimbursable diagnosis since the patient did not have a left foot. Now, this is one of those really simple, silly mistakes that cost the hospital $10,000. We did an appeal. It turned out there were a lot of documentation lapses. Right from the H&P to a copy-paste progress note to the discharge summary. The radiologist got it right because that's what they read it. The nursing staff got it right, but right from the physicians, physician assistants, the nurse practitioners, they all documented the wrong thing. And so it turned out we had to do a provider liable process in this, do an appropriate correct documentation addendum to this chart and the discharge summary, sent it over. We're at the 4th level with the insurance company saying it was an honest mistake. But the process has taken, this hit the hospital for about 8 months now. So the simple 10,000 payment that they could have got now has been held at 8 months. And that's what we say. ICD-10 pushes towards right documentation. So they did the right thing by putting the left and right. They just didn't put the right left and right. They put it on the other foot. I think if the patient did not have the amputation, the scrubbing of the data would not have shown this. This case would have gone through. Again, it would have been wrong documentation, which shouldn't be the case in any case. But this was caught because of the prior history of the amputation. So how does this affect physicians? And with the 2 midnight rule now being more than 3 years old, there was a shift from complex medical decision making to time-based definition. So if your expectation is patient is going to require more than 2 midnights, then that is appropriate for inpatient. But for whatever we do, documentation is critical. That's the rock solid foundation, so that whatever rules, whatever laws, whatever sub-regulatory guidance comes over the next few years, our cases, the hospitals do get reimbursed, and the documentation in the chart is right, not only for the provider, for medical legal purposes, but for the patient, for the beneficiaries process. So there are some links to the guidelines that we have talked about, and there's some from CDC, some from the Infectious Disease Society of America, and these are really good for reading for providers. So use these links. People with LMS, press these links, they'll take you to the article directly. All right, friends, do we have any questions from you at the moment?
Dr. Bahuja, I have a question.
Yes.
When we look at cases of cellulitis, and sometimes it doesn't meet the interqual or Milliman criteria for inpatient, and the physician documents that the patient would need 2 or 3 days of IV antibiotics, and that patient might need at least 2 midnights. So in that case, previously it would have been 2 or 3 day observation stays. How do we deal with it now?
So, I in all my presentations, I talk about interqual and Milliman as screening guidelines that are out there. Medicare does not endorse any screening guideline. Medicare makes it, wants us to follow the 2 midnight rule. So if your patient is a pure Medicare patient, where each of the days that this patient is in the hospital is medically necessary for the treatment of cellulitis, and it's expected that they will cross 2 midnights, or they have actually crossed 2 midnights, then inpatient is appropriate. Now, having said that, if this is a private payer where they have, the hospital contract and the payer contract is, we are going to follow MCG or interqual guidelines, then you are bound by what their rules are. But for Medicare Advantage plans, that's where the gray zone comes in, is what do they follow. All Medicare Advantage plans are bound by Medicare rules, so they cannot arbitrarily say we don't follow the 2 midnight rule, or we don't follow MCG or interqual, we follow our own thing. If it's a time-based diagnosis, time-based stay, and each day is medically necessary and has been documented, then go ahead, bill inpatient. That is the appropriate thing to do.